Thank you for joining us. I would like to welcome you all to the SBIRT for Youth Learning community. At this time, I'd like to go over a few housekeeping items for today's webinar. We'd like to encourage you all to participate in today's webinar via 3 methods. First, if you have questions for the presenter or are experiencing any technical issues, please use either the chat box or the questions pane to communicate your questions. Periodically throughout the presentation, the presenter will stop and ask for questions, at which time I will read aloud any questions that have been submitted. Again, you can submit questions via the comment or questions box. Throughout the presentation, all participants will be on mute. If for any reason you would like to be unmuted, please click the raise your hand request and unmute your personal phone or mic. I, as the organizer, will unmute you to speak directly to the presenter and group. You are also able to collapse and expand the GoToWebinar panel via the arrow button should you choose. At this time, we'd like to go through 5 poll questions. We want to get a picture of the demographics and SBIRT experience of the audience. These questions will appear on the screen as an interactive poll. Please select the best answer as it applies to you. Our first question is, what is your current professional role? Are you a counselor, therapist, social worker, or case manager? A nurse, nurse practitioner, physician, or physician assistant? Program or unit manager, university student or faculty, or other? Okay, I want to thank everyone for participating in that poll. I'm now going to share the results. If you selected other, feel free to share within the chat box or questions panel what profession you're in. Our next question, what field do you represent? Are you in mental health, addictions, physical health, education, or EAP? Okay, I want to thank everyone for participating in that poll, and I'm going to share the results. See that we have a majority in mental health and the addictions field. For our third question, do you conduct SBIRT interventions? Okay, I want to thank everyone for participating in that poll, and I'll share those results. You can see that the majority of the attendees do not conduct SBIRT interventions. And for our next question, do you see your agency using SBIRT? Okay, I want to thank everyone for completing that poll, and I'll share those results as well. We see the majority do see their agencies using SBIRT. And for our last question, in which setting are you most likely to implement SBIRT or assist others to implement SBIRT for youth? School or school-based health centers, juvenile justice settings, job placement programs like Youth Builds, primary care, or community mental health? Okay, I want to thank everyone for participating in that poll, and I'll share those final results with you. And the majority of our audience sees this implemented in primary care. And I just want to share with the audience that we had some additional comments in the questions box in terms of profession, such as an SBIRT network coordinator, a clinical trainer, prevention specialist, substance use disorder prevention coordinator, and working in the mental health and addictions field. Thank you for all completing those polls. We really appreciate you being interacting. I want to take a moment to tell you about the National SBIRT ATTC Technology, the Addiction Technology Transfer Center. We're funded by SAMHSA, Substance Abuse and Mental Health Services Administration, and we offer a suite of services that you can find on our website. Some of these services include our National Registry of Qualified SBIRT Trainers. You can search the registry by state to find SBIRT trainers within your region. We offer monthly live webinar series on a variety of SBIRT topics, as well as have a library of free recorded webinars that can be accessed from our website. We offer technical assistance and consultation at request. This might include general information requests or more in-depth training requests. We're open to collaboration with various organizations and entities. Our website also hosts many online resources, such as downloadable products that are easy to use, like toolkits for practice and digital tour guides, which are 2 to 4 minute overviews of specific products. You can also sign up for the SBIRT Alert, our electronic newsletter, to receive training and webinar announcements, as well as additional SBIRT information. And lastly, the IRETA blog is hosted through our parent organization, and it offers stories of SBIRT in the real world. All of these, as well as additional resources, can be found at our website. I'd like to mention our free self-paced online SBIRT for Adolescents course. This course is based on a webinar presented by Dr. Sharon Levy on the application of SBIRT with adolescents. It's hosted on our website and is approved for continuing education credits. Some of the goals of this learning community are to examine the application of SBIRT in a variety of youth settings. We want to create a community of providers who have a similar interest in implementing SBIRT for youth, as well as facilitating the sharing of experiences with implementing SBIRT in youth settings. And finally, as a learning community, we encourage you to return to upcoming sessions. Our next meeting is January 26, 2016 from 1 to 2 p.m. Eastern Standard Time. We also have an online webpage that lists resources specific to SBIRT for youth and want to provide technical assistance such as support for implementation, coaching, and troubleshooting by request. You can contact us at sbirt@attcnetwork.org. At this time, I'd like to introduce our speaker for today. Amy Pepin is a consultant with the Community Health Institute, JSI. She provides technical assistance and training to New Hampshire Youth SBIRT Initiative implementation sites. Amy has more than 20 years experience working with and for youth and families, providing, developing, and supporting strategies and services that prevent, reduce, and treat alcohol and other drug problems. Ms. Pepin is an MSW and a licensed clinical social worker and a certified prevention specialist. Amy, if you're ready to go, we can turn things over to you. Amy, can you hear us?
Oh, I am here. Can you hear me now?
We can.
Perfect. Fantastic. Okay. So today I'm going to share information about New Hampshire's Youth SBIRT Initiative, which we call Screen and Intervene. But in order to do that, I really need to orient folks to New Hampshire and what's going on here. New Hampshire is a small state by any standard. We've got about 1.3 million people. We're 9,000 square miles, and 20% of our population are under 18 years old. Significantly, we are predominantly white, with 94% of our population describing their ethnicity as white alone. Our largest city is a little over 100,000 people, and it's 86% white. And we are surrounded by Vermont and Maine, which are other very rural, predominantly white states. Massachusetts, underneath us, is what folks think of typically when they think of New England. And Massachusetts has almost 7 million people and a much more diverse population. So I say all this to understand the context of our current first-in-the-nation crisis. We also have the opportunity, as folks know, many people from across the country, the only way you know New Hampshire is because we have the primary and candidates get on TV and say things from New Hampshire. So a lot of the things they have been saying have been about addiction and about the heroin epidemic in New Hampshire. Heroin epidemic being shorthand really for a opioid epidemic in our state. What is really heartening is that unlike in past election cycles when the topic of substance misuse or substance use disorders or addiction comes up, this year we've had some incredible reaction and statements by candidates. There hasn't been one candidate who has demonized folks who are using substances or who are experiencing substance use disorders. And several of the candidates have put forth really strong plans to address the opiate epidemic, particularly nationwide. So that's current context for our work. We're in a state which has historically ranked very high in the nation on rates of use of all substances across all age groups. We're particularly right now struggling with alcohol and other drug use in our young adult population. We've been working very systematically for years to address adolescent substance use and have seen alcohol and other drug use go down among that population, where unfortunately marijuana use is going up, as we see in other places in the country. As you see in this chart, our 12 to 17-year-old rates still look atrocious at third highest, but we used to be #1 in almost everything. So we're feeling pretty good about that right now. But there's an awful lot of other work to be done, and we know we're not close to addressing this universally in the way that it should be. Recognizing that, we have, as a state, done systematic planning through our Governor's Commission on Alcohol and Drug Abuse Prevention, Treatment, and Recovery. This is a Governor's Commission that includes the heads of all agencies, government agencies, including the Attorney General, Health and Human Services, Safety, etc., Corrections, and but also other key sectors from across the state, including the healthcare or medical sector. And in doing this strategic planning, several years ago, we laid out strategies across various levels, from the government level to the community level to the individual level, what can one do, and also across sectors. So that was very serendipitous in that we have close partnership in this planning with our New Hampshire Charitable Foundation, which is the largest foundation in our state, and they have prioritized substance misuse as a funding area. With their vision and leadership and that strategic plan in hand, they were able to go and talk to the Conrad Hilton Foundation as that foundation was engaging in work around youth substance misuse prevention. They particularly were interested in funding, screening, and brief intervention, and as that was a strategy that was outlined in our state strategy, the Charitable Foundation was there to say, look, not only do we think this is a good idea, but we have support for this idea, you know, from entities across the state that folks want to do it. And they were able to partner with Hilton and bring resources into the state to invest in screening, brief intervention, and referral to treatment in what we have tagged our Screen and Intervene initiative. The initiative includes a policy arm working on advocacy around rules and regulations that may impede the smooth provision of SBIRT services, and our policy partner, New Futures, is one of the entities that was crucial in advocating for the expansion of Medicaid in our state, which included, for the very first time in New Hampshire, substance use disorder services to be reimbursable by Medicaid. So for the first time, just a little over a year ago, we started to have reimbursement for substance use disorder services in our state, which, again, all of these parts coming together, we have a growing epidemic, which is, you know, shining a light on this issue and really making people wonder, what can I do, what can I do? We have funding mechanisms in place that were never there before through parity and Medicaid expansion. And we have this fantastic funding coming in from the Hilton Foundation to incentivize folks doing this work. And then we've got this policy arm making sure that the barriers are coming out of the way. So in this environment, over the past year and a half, 7 organizations have applied to the foundation for funding, and currently 15 primary care sites across the state are implementing Youth SBIRT. My organization, JSI Research and Training, provides the training and technical assistance to those sites and support to the foundation for the grant program. So the foundation decided that really took a hard look at the existing evidence, thought ahead of time about sustainability, really, you know, wanting to incentivize SBIRT being in place, but not create a system that required grant funding to move forward. That they wanted to incentivize the creation of something that would then become a regular part of healthcare provision and primary care for years to come. So the parameters for the grant funding for the Youth SBIRT Initiative include things like incentivizing EMR modifications or workflow improvements, covering staff time, any, you know, non-billable hours, times that they're in meetings, times they're on phone calls, times that they need to travel for training, any of that can be covered. But what is not paid for by these grants is any additional staffing or costs for activities that would not continue beyond the grant period. So if a site determines, oh, our flow would be a lot easier if we had another medical assistant to be able to input screens, for example. The charitable foundation dollars may not be used to hire that medical assistant because they are not going to use funds for something that cannot be sustained after the grant period. On the other hand, making EMR modifications that would then continue well beyond the grant activity period is something that makes perfect sense. And we've seen the grantee partners really understand and embrace this notion of what the grant funds should be used for. The goal really and the reason for targeting primary care is a sea change in where alcohol and other drugs is discussed and where it is addressed. Currently in New Hampshire, I'm sure that I would be hard-pressed to find a pediatrician that would tell me, oh no, I never ask about that. But on the other hand, once we explore a little bit further about how they ask about that and how they talk about that, they become very open to looking at what, if they're using evidence-based tools and the other kinds of practices that we can support them in through this SBIRT process. So really, when participants come into the grant, they are, they're agreeing to have a team. They're agreeing to participate regularly in our community of practice, our learning collaborative. They are agreeing to share what works and what doesn't work. We're very fortunate that both Hilton and the New Hampshire Charitable Foundation are very, very interested in learning and see just as much value in what doesn't work as in what works. So we've been very fortunate to be able to create a learning environment where grantees feel really comfortable to share what works and what doesn't work, and really help each other from learning the same lessons over and over again. In order to be an applicant for the grant, you have to have an electronic medical record. We really saw that as one of the key pieces of sustainability. Most primary care providers, there are very few primary care providers left in New Hampshire who don't have an electronic medical record, and if they don't, they're in the process of getting one. So this is not as cumbersome a requirement as it might be in other places. The other key piece was that participants had to have either integrated behavioral health on site or a committed referral partnership. Didn't mean they had to have one in existence. If they wanted to go out and create those partnerships in order to apply for this grant, we encourage that, and we have seen that happen in one site. And then the other thing, of course, that they agree to do is to report data and let us know what's going on. So benefits to the applicants, they've told us that one of the crucial benefits beyond what they anticipated, which was that they would be integrating this alcohol and drug information into the health information about their young patients. Beyond that, what they've really found is that they've had an ability to scrutinize their practice and their flow and their decision making around some of the things that they do with young patients, and make some changes that they've been wanting to make for a long time but never had the time to just pause and think about them and be able to do it in a systematic way. So we at JSI provide the training and technical assistance through Learning Collaborative, through monthly webinars, through teleconferences, training. We do face-to-face consultation, phone consultation, you name it. People get in touch with us and we help them figure stuff out. We do presentations and have just completed in October our second annual statewide summit, which was very well received. The other thing that we have done and just released the updated version at the summit in October is to compile the lessons that we're learning and our suggestions and recommendations for how a primary care site in New Hampshire might implement SBIRT into what we call the playbook. We very intentionally named it the playbook because it is not a step-by-step guide. You don't have to start at one and go to the end. You can jump in where you need to focus in order to get your practices, SBIRT, up to the standard that you want it at, or if you're starting from scratch, to start where the energy is. So we recognize that people don't have to make all these decisions exactly in a particular order. We encourage people to access the playbook and other resources at the Youth SBIRT Initiative website, which is sbirtnh.org. This is just a quick example of some of the webinars we have upcoming, and I'm going to describe our specific components of SBIRT. But before I do that, are there any questions so far?
Amy, we don't have any questions currently in the questions box. I just want to remind everyone that you can submit any questions you have to the questions panel or the chat box. And if you'd like to ask a question directly live onto the webinar, feel free to use the raise your hand option and we'll unmute you.
Great. Please do ask questions. I am sure I am not going to be nearly as thorough as would be helpful for some folks. So this is our visualization. This is our conceptualization of the SBIRT process. And typically, and I'm sure as many of you are involved in mental health and substance use work, you have seen the triangle, and you know you have the universal population at the bottom, and it goes up, up, up into that little pinnacle. And we've seen SBIRT depicted that way as well, and with the universal screening at the bottom and brief intervention in the middle and referral to treatment in the top. And while it's a really accurate and I think very helpful visual in terms of people understanding the number of folks or the scope of the work at the different stages of the process, we found that it was unidirectional and that our message over and over and over again, absolutely everywhere to anyone that will listen, is that SBIRT is a process over time. This is not a one and done thing. You can't SBIRT someone, you know. I did my SBIRT today, it is done. That is not how it works. It's an acronym for a process with you know, a variety of components depending on how they're defined in any particular site, and components that need to happen over time and over and over and over again. So we really felt like this more accurately depicted what we're talking about when we're talking about SBIRT. Defining screening for us, we're talking about universal screening in the New Hampshire Youth SBIRT Initiative. Sites are either using the craft, which I'm sure everyone is aware of if you've worked with adolescents at all in the last 20 years around substance use. But the other screening tool, which we're actually really excited about, is Dr. Sharon Levy and the Boston Children's Hospital team has created a tool which they call S2BI, screening to brief intervention, and it's very brief and really gets you to quantity and frequency questions that are extraordinarily helpful in delineating the level of risk and then what kind of brief intervention conversation needs to follow up from there. So we have sites that are using it, and we have sites that are using it in combination with the craft and are finding that then practitioners really have the information that they need to do a good brief intervention that doesn't take time up asking them about these factors, quantity and frequency questions or risk factors. They can kind of hone in on the things that have already been identified and use those few minutes that they're going to take, because when we say brief, we're talking brief, to use those few minutes in the best possible way. The other thing I want to say about screening is that almost all of our sites over time have moved that screening out of the practitioner's hands. As I said before, you know, I'd be hard-pressed to find a pediatrician or a family practice doc or nurse practitioner who wouldn't say, well, of course I would screen a young person. And in our case, we're talking about people 12 to 22 years old. Of course, you know, I would ask a 15-year-old about alcohol and drug use, or of course I would ask a 21-year-old about alcohol and drug use, but for the most part, not using an evidence-based screen, not using it in the way that it was written, and not necessarily following through with an evidence-based brief intervention. So, and the other piece is that they would do that verbally in their meeting with the young person, and are kind of loath to give that up, you know, like, well, wait a minute, this is important information and I need to ask about it. What we've found is at all but one of our sites, the practitioners are no longer answering the question. Asking the questions. The screening tools are happening outside of the room, and they are maximizing the use of the electronic health record to the extent possible, so that the practitioner has that information in front of them when they go into the exam room with the young person, but they don't have to ask the questions, which saves them a little bit of time to be able to actually engage in a conversation about the answers. And as sites have explored that flow, as I said, almost all of them, and the last one has more latitude in terms of the length of time that their practitioners spend with their patients, so they don't feel as time crunched. Everywhere else, it was, wait a minute, how are we going to squeeze in this brief intervention thing? And one of the ways they found in the flow was to take the screening out of the practitioner's hands. So when we're talking about brief intervention, when we say SBIRT as a term, or when we say brief intervention as a term, they can have myriad definitions. You know, you could be talking about 50 different things because the process is so complex. The way that people put it together in any given site is a little bit different, and needs to be, because it needs to be appropriate to the resource availability at that site and what flow will work best for them. But when we're talking about brief intervention in the New Hampshire Youth SBIRT Initiative, we're really talking about a conversation using some motivational interviewing tools that is brief, 3 to 7 minutes, that uses techniques but is not about being an MI expert, that's being primarily done by the primary care provider. And that is patient-centered and understands that this is a process over time. It's not going to be magic that that a doc has a 5-minute conversation with their 17-year-old patient who then never smokes marijuana again. That is not the expectation. The expectation is they're opening up a dialogue over time, that they are supportive and a resource for that young person, that they can identify a need for treatment if such a need exists, and that they can identify the healthcare risks related to that young person's use, and that they can recommend that they cut down or stop, as the case may be. And with marijuana, we would always recommend stop. But the other piece of that being that it needs to be a patient-centered conversation, and there needs to be a lot of listening. And that sounds like a lot to happen in 3 to 7 minutes. But what we're finding, and I think what people across the country find as they embark on this brief intervention adventure, is that some really great conversations happen in that brief period of time, and that they can have an impact on young people's lives, especially over time. Oh, I skipped a slide. The last piece, of course, is referral to treatment, which I unfortunately, for some reason, have blockaded. Referral to treatment is a huge problem in New Hampshire. We understand that that is the case in many places across the country. New Hampshire has a woefully inadequate treatment system for adults and a virtually non-existent treatment system for young people. And when I say system, I mean something that has, more than just outpatient in it. We really do not have a continuum of care for young people in the state, though it is being built. More and more services are becoming available. And so, of course, this is something that we hear consistently as a concern from primary care sites that are entertaining the notion of implementing SBIRT systematically. What we've found is that sites that are implementing SBIRT are not identifying that many more young people that require referral to treatment. What they really are identifying is exactly what the really meets the goal of this initiative, and is very exciting for all of us that that endorse this as a strategy and as a prevention and early intervention strategy, because what they are finding is young people in early use, they're finding young people with lower rates of use, and they're starting the conversation now and intervening in that use now. What impact does that have? Well, we don't know that yet, but process over time. What we would hope would be that if a young person's health care from the time they're age 12 includes the topic of alcohol and drug use and includes an open conversation around alcohol and drug use, that should that ever become problematic for that young person over the course of their life, their primary care doc is a place that they would go to talk about it and figure out how to get help. Right now, that doesn't happen in a systematic way. And when young people do go to their doc, the doc doesn't always know what to do or what to say. So it's our hope that Youth SBIRT in New Hampshire is going to change that over time. Okay. I wanted to show you from our playbook, the implementation checklist. You know, I've just talked about the components of SBIRT. So we talked about the S, the BI, the RT. Well, we know that that's not all the components of SBIRT. Our playbook has 15 different components, and the implementation checklist breaks out components under each one of those plays. So we know that it's a really complex, dynamic process to implement SBIRT. And initial implementation sites really wanted a visual so that they could understand what they had, where they were at in working on things. That wasn't a complex work plan, but was a summary. So we developed the implementation checklist, and as you see, I couldn't fit it all on one slide, so because it's that long. As I said, 15 plays, and you know, screening, intervention, brief intervention, referral to treatment are just the three middle ones. Confidentiality is a key play, and we challenge implementation sites to consider confidentiality in every single decision that they make, confidentiality and privacy of that young person's information. The other key thing that I would really like to point out, and that you saw on the circle, if you were paying attention, was that follow-up is the other key component to SBIRT. And you know, it doesn't lend itself well to an acronym, but it's absolutely key to the process and always has to be discussed. Screening, brief intervention, referral to treatment, follow-up. Any patient that gets referred to treatment should come back, and information should come back to the primary care provider as they would when they send folks out to any other specialist. But any brief intervention that is done, which recommends a change in the use pattern, should also be followed up. And certainly it's up to the primary care practice and provider to determine, you know, who and how often needs that follow-up. And we see a lot of different answers around that, but following up is incredibly important. As I said before, we have 7 provider organizations currently in the initiative. We have 15 primary care sites. They're pediatric practices, they're family medicine practices, they're federally qualified health centers. Some of them are practices in small hospital systems. Some of them are in large health systems. We really have a variety. The participant sites have screened over 2,000 youth as of the end of September. The goal of the initiative is to screen 10,000 by the end of next year, and we think we're well on our way to surpass that. The grantees are in different stages of implementation. We started with an initial cohort of 5, but since then have brought folks on as they've been ready to come on. So we have grantees in the installation stage of implementation, and we certainly have those that are still in preparation and haven't even started screening yet. We have grantees who are using their, who have created flow where medical assistants verbally ask the screening, and we have grantees who have sophisticated screening tools with skip patterns and all kinds of really cool stuff on tablets in the waiting room that automatically populate their EMRs. we wanted to be able to highlight some of the critical success factors and some of the challenges, and they really are two sides of the same coin, with team, with confidentiality, and with the role of the primary care provider. A key to success is having a strong team with buy-in from key leadership, representation across the different disciplines in the practice, and an enthusiastic champion. And while it is always fantastic in practice change to have a medical champion, we've really seen that an enthusiastic champion from any of the disciplines at that practice site, the one that gets everybody to keep coming back to the table, the one that gets excited about it, the one that reminds them why they're doing it and why they care so much about it. And sadly, in many places, that's because they've lost patients in our current epidemic of opiate use, and they really see this as a way to head off that trajectory for some of their young patients. So having that enthusiasm and that sense of mission on the team, whoever it sits with, has been crucial. And then the other piece, of course, is that they actually get together as a team on a regular basis. We have seen teams that are beautiful on paper but don't really happen, and we have seen teams that don't look like much on paper, but they get together every week and they have gotten everything done, and have been able to overcome all kinds of potentially huge problems in at their sites or in their organizations. So leadership is key, but you do not always have to have all of the key leadership at the table for the meetings. What you do have to have is the folks at the table empowered to actually make some decisions. The other really big one that we hear about, and that I'm sure folks hear concerns about on a very regular basis, is patient confidentiality or privacy. It was a huge perceived barrier in our first cohort when we did our initial site readiness assessments. We just went and really chatted with the teams at every single site and asked them, you know, what were they worried about, what did they need to know more about, where did they think they were all set, and universally they were all concerned about confidentiality. Very, very concerned, like how do we ask these questions and can we even write down the answers, and very concerned about what they could and could not do. And what we found the further we dove into it is that it's actually a very low barrier. Once the sites have the information that they need around what a proper release of information looks like, when you're actually required to have one, they need to explore where they're at in terms of what they have in writing for written policies around privacy and patient confidentiality beyond HIPAA. Everyone has HIPAA documentation. But again, we're talking about on the pediatric side of this population, there's already confidentiality standards in pediatrics around sexual health, birth control, a number of other things. And what we found was that sites did not have written policy that acknowledged or addressed in a comprehensive way how it was that confidentiality was maintained for their young patients. They all knew they had to do it. They'd all figured out ways to do it, but had not necessarily talked about it out loud. And this was something that we did not want to, see anyone try and do that way, that it really needs to be overtly discussed and agreed upon by the team, by the organization. And that we were able to support people in the different sites in that process, and it was really a non-problem. There is a confidentiality play in the playbook and 2 appendices that we worked on with the Legal Action Center using their information to support health centers and healthcare practitioners in making confidentiality decisions around alcohol and drug information. Whoops. The other key thing, which I already talked about a little bit, is the role of the primary care provider. And we have really found across the sites that they have decided that the primary care provider is the way to go in terms of conducting the brief intervention, and we have seen the process be most successful when that's what happens. And when they have a process in place for scheduling follow-up. We also have a number of sites that are now screening across the lifespan because once the primary care provider feels confident and competent in that role of doing brief intervention, they're going to do it more. We wanted to make sure folks know that this is that there is an evaluation process in place, not just our internal evaluation that JSI is providing for the Charitable Foundation, but much more broadly than that. The Hilton Foundation, in collaboration with ABT Associates, is evaluating SBIRT grantee sites across the country. And we're very excited about that. And all of our grantee sites feed information up into that national evaluation. The key piece, of course, is that the reason to incentivize and provide grant funding around SBIRT implementation is to sustain it and grow the implementation of SBIRT over time. It's really our vision in New Hampshire that screening and brief intervention in primary care will just be a standard of practice. And we would love to see that happen across all primary care sites within the next 5 to 10 years. What we know in order for that to happen is sustainability in the existing sites, which requires organizational buy-in and provider champions. We know that it requires the flow and EMR modifications, and a real attitude of this is what we do here, with the foundation of and we can get paid for it. If there's no reimbursement, it's not a sustainable process. And what we're seeing is sites, depending on how they determine that flow and who does what when, are looking to be reimbursed in a little bit of different ways. And so in the next year or so, we'll actually have a lot more information and be able to make recommendations about which ways seem to be the most sustainable. Lastly, I just wanted to share that while the New Hampshire Youth SBIRT Initiative is currently working with 7 grantee organizations and 15 sites, we're actually in the process of potentially onboarding 3 more organizations and 10 more sites before the end of this year, bringing us to 25 sites across the state. And in some states that wouldn't sound like a lot, but remember that we're in New Hampshire and we're not that big. So 25 sites is pretty exciting. On top of that, the Department of Health and Human Services in the state of New Hampshire is requiring going forward and starting in the next fiscal year that all community health centers in New Hampshire will do SBIRT for their adult and pregnant women. And so that's 18 additional sites that will be doing adult SBIRT. About half of them have either already started or have plans to also do youth SBIRT in the next year. And we think all of them will over the next several years. And finally, very exciting news earlier this fall was that our New Hampshire AHEC, the Association of the Healthcare Education Collaborative, received a SAMHSA grant to provide SBIRT education, to incentivize SBIRT education in a collaborative of 11 higher ed institutions in the state. And that's very exciting. So our nursing and social work, our medical assistant training programs are all going to have SBIRT training in them, as well as the Geisel School of Medicine at Dartmouth Hospital. So, I mean Dartmouth College. So we're really excited about that. We feel like we're really have a lot of forward momentum right now. And I think that is all the time I have. Do folks have any more questions?
We do. We have quite a few questions here, and I don't think we'll be able to answer them all. So for the attendees, we will send Amy a list of everyone's questions that are not answered, and then disseminate her responses via a Word document following the webinar. But we do have time for one or two. So the first question is, how could SAMHSA make SBIRT more available for youth? And has SAMHSA funded any youth SBIRT work in New Hampshire?
That is a good question. New Hampshire did not get a state SBIRT grant, and I don't believe anyone that any organizations have been funded specifically to do SBIRT. HRSA, on the other hand, has required SBIRT in a number of grants, their behavioral health integration grants and some other ones. So we actually have, that is why some of the federally qualified health centers are ahead on adult SBIRT implementation because their HRSA funding required it, special grants that they got, not their base funding. In terms of what could SAMHSA do to further incentivize youth SBIRT, I think that SAMHSA is continuing to do state youth treatment planning grants and youth treatment implementation grants, and that that strongly recommending SBIRT as a component to that and providing some incentivizing funds. Again, it's a complex process for sites to get up and running, and they really need some funding so that they have time to stop and think about it. And I think being able to incentivize in that way would be very helpful.
Okay, great. We have time for one more question, after which I'll just quickly go over the CEU and evaluation information. So our last question is, how many minutes does the brief intervention have to be for billing purposes, and can the brief intervention of 3 to 7 minutes be reimbursed? In the SBIRT Medicaid codes, the conversation needs to be up to 15 minutes for reimbursement.
That is the best question ever, because that is the primary question of how on earth do we figure out this reimbursability problem. So, and we're actually in the process of getting clarification from our state Medicaid authority around what does that code mean, because some folks are reading it as up to 15 minutes and other folks are reading it as at least 15 minutes, and I don't think it means at least 15 minutes, but I don't think it means 2 minutes either. So I don't have a good answer. But we've actually asked our state to provide guidance in writing that we can disseminate to sites. And again, our reimbursement and benefit around substance use stuff is so brand new in Medicaid that a lot of these kinds of questions are coming up, but particularly as we're trying to spread the practice of SBIRT, we need to have solid answers to that. But yes, that's what ours say too. It's a 15-minute code or it's a 30-minute code, and the way the flow works, that doesn't make a lot of sense.
Okay, thank you very much, Amy, for such a great presentation. All of the remaining questions that have come in, again, we will share those with Amy after the webinar and then disseminate her responses. At this time, I'd like to go over our evaluation and CEU instructions. You're going to receive a few emails from us following the webinar. In these emails will be a link to the recording of the webinar as well as a PDF version of Amy's slides. Also included in the email is a link to our evaluation. Our grant evaluators are required and pleased to collect feedback from all event participants. Completion of this evaluation is critical to maintain our funding and continue to provide quality education and materials. Your participation is appreciated, and the evaluation should take no more than 2 minutes of your time. Immediately following the evaluation is the continuing education information. You can download a certificate of attendance or purchase a free NADAC or PCB CEU. Should you choose to skip the evaluation and proceed directly to the CEU information, just leave all answers on the evaluations link. Again, we want to thank everyone for their participation today, and if you have any additional questions, feel free to contact us at info@ireta.org. Okay, thank you very much, Amy.
Thank you.